If your doctors prefer to scan Philhealth case rate codes to look for highest case rate package for their discharged patients, your hospital will be in trouble. Upcasing or upcoding is a type of fraud where healthcare providers submit inaccurate billing codes to Philhealth in order to receive inflated reimbursement. These false code submission indicate that doctors provided patients with treatments that were more complex, more costly, and time-consuming than what they actually received. Since the implementation of partial case rates in 2011 and all case rate in 2013, I have seen so many upcasing cases. Some are unintentional, while others are blatantly intentional. Now, during my time in Philhealth, we discovered that upcasing of claims are either doctor-induced, process-induced, or patient-induced. Now, the common factor among the three is the poor awareness of hospitals, doctors, and patients on rules and policies of Philhealth. Now, I will give you a classic example. A patient with lower respiratory tract infection admitted in a level 2 hospital. The signs and symptoms were mild cough and colds. Now, unfortunately, the admitting physician upcased the diagnosis to community-acquired pneumonia moderate risk, even though the signs and symptoms were not a match. So, CAP-MR or community-acquired pneumonia moderate risk has a value of 15,000. So, this means mild illnesses are diagnosed as toxic illnesses in order to collect a higher fee. So, after several years, claims post-audit was done and the hospital is now talking to Philhealth Legal. How does this happen? And when does upcasing occur? And how can you prevent this? Now, in my experience, these are common upcasing scenarios in the hospital. I have seen this in both private as well as in government hospitals. So, scenario number 1. The doctor intentionally seeks higher case rate package. So, this usually happens as the doctor writes or encodes the final diagnosis during the discharge of the patient. Now, if the doctor is not familiar with the case rate codes, the doctor scans the case rate annex list for illnesses and codes with high rates. So for surgical procedures, the surgeon scans the RVS codes for procedure with high rates. So this false diagnosis is then converted into an ICD-10. Now, what happens here? So the doctor's act is intentional. The doctor uses false codes to get higher reimbursement. Now, there are times that the hospital has no idea on the fraudulent behavior. But there are times the hospital knows about the fraudulent behavior. So, however, the hospital prefers not to intervene because of the assumption that the doctor's management. Now, unfortunately, in either way, the hospital is still liable. Now, the next scenario is different. Okay? You have a non-medical hospital staff is assigned to select the perceived best diagnosis as case rate package for the patient. So, in this scenario, the doctor has no role in selecting the case rate code. However, the doctor signs the form. Now, by signing the form, the doctor agrees to the selection of the code. So, this scenario may look efficient, but it's prone to error. Now, this is applicable to patients with multiple diagnoses upon discharge. Now, I have seen non-medical staff, hospitals, wherein they select the best diagnosis without clear guidelines on how to do it. Most of the time, the best diagnosis equals the highest case rate code. Now, here's the thing. The highest case rate code is not always the main condition and not related to the clinical management. Now, this is when the hospital and the attending physician gets in trouble. Now, here is a good example. Okay, a 60-year-old female admitted for an elective thyroidectomy. So, on admission, the chest x-ray was taken. The patient had no cough and had no fever. However, the chest x-ray result revealed pneumonia. So the surgeon decided to defer the surgery, and it was basically a one-day admission. So the final diagnosis on discharge was anterior neck mass and pneumonia. So this could have been very easy for everybody except that the hospital staff assigned to choose the case rate code used pneumonia, moderate risk as the case rate code. So it was one-day admission, there was no fever and no cough, and it was coded as CAP-MR with 15,000 as case rate. Now, the case is in Philhealth legal. So, the next scenario, or rather the last scenario, is when the doctor alters the final diagnosis per request of the patient. Now, believe it or not, this is actually happening. So, the attending physician discharges the patient. Then, upon processing the bill, the doctor gets a request from the patient's family or a request from the patient. So, they will ask the doctor to change the final diagnosis. Most of the time, the patient will offer their own diagnosis with a high case rate package. So, the patient will insist that this is good for the doctor and it's good for the patient. So, the patient's benefit will increase and the doctor's fee will also increase. So, doctors with poor awareness on Philhealth rules will actually agree with this request. Now, the doctor thinks he was helping the patient by using a false diagnosis. The doctor will realize that this was fraud once he gets a letter from Philhealth Legal. So, most hospitals will argue that the diagnosis is a doctor issue. The hospital has no right to intervene in the clinical management and diagnosis of the doctor. Now, in some aspect, this may be true, but this is not absolute. So, as owners or managers of the hospital, you are liable or accountable to what is happening in the hospital. This is written in the performance commitment that you signed. So, the best way to prevent this is to manage your medical staff. Create a hospital policy prohibiting upcasing and upcoding. So, medical directors must step up and police the rank of the medical practitioners. Then, create a medical claims review to assess the claim prior to sending to Philhealth. Now, friends, check out the next video on medical claims review if you want to learn more. I'm Coach Doc Ben. See you in the next session.